The following video is our technique for a bridge-enhanced ACL repair. The disclosures of our senior authors are listed below. A diagnostic arthroscopy is performed to confirm the tear type. In this patient, there is a proximal avulsion of the ACL. The stump is inspected for length and integrity of the tibial insertion. An arthroscopic elevator is used to separate the ACL stump from any scar tissue or adhesions. Attention is then turned towards suturing the ACL stump. A first-pass mini suture passer is loaded with an ultra-braid suture, and the stump is sutured from distal to proximal in alternating directions. Various suture configurations can be used depending on the tear type. Once both suture limbs are exiting from the proximal end of the stump, this step is complete. Next, a 4.5 mm round burr is used to prepare the ACL footprint. A 2.7 mm cannulated drill is used in conjunction with an ACL outside-in guide to penetrate the notch. A loop nitinol wire is passed through the drill sleeve and retrieved with an arthroscopic grasper. The ACL stump repair sutures and one additional loop suture are then passed through the nitinol wire and shuttled out of the superolateral incision. Tensioning the ACL repair sutures will approximate the stump tissue to the femoral attachment site. The tibial footprint is then drilled with the same 2.7 mm cannulated drill and a standard tibial ACL drill guide. Again, a nitinol wire is passed and retrieved for later use. The ACL repair sutures are passed through a titanium button that is preloaded with a mini tape suture functioning as an internal brace. The internal brace sutures are then passed through the loop suture and shuttled out of the medial portal, thereby bringing the button through the IT band and onto the lateral cortex of the distal femur. Here are the sutured ACL stump and internal brace prior to bare implantation. The medial portal is extended proximally for the medial arthrotomy. The knee is irrigated with an antibiotic solution using a bulb syringe. A straight, free needle is used to load the internal brace sutures through the bare implant. The free limbs of the internal brace are then passed through the nitinol wire and shuttled out of the anterior incision on the proximal tibia. The patient's blood is collected and approximately 2 cc's are injected into the center of the implant. The remaining of the 10 cc's are applied to the sides of the bare implant. The tibial end of the bare implant is not hydrated to allow for a firmer surface against which to insert the implant into the notch. Under direct visualization with the use of retractors, the hydrated bare implant is slid down the internal brace sutures into the notch while the knee is gently brought into extension. The tibial limbs of the internal brace are tied over a cortical button with the use of a knot pusher. The ACL repair sutures are likewise tied over the femoral button.